Good morning, everyone. Welcome from Mount Sinai, New York on November 22nd, this morning at 8:06. We are back again for another live case for peripheral interventions. Before I take you to the lab, as always, if you have any questions, please email us at info@peripheраlinterventions.org, or you can go to our website, peripheраlinterventions.org, leave comments. You'll be able to see this case by the end of this week in the archive section. And of course, you can go back and see any of our previous live cases in the archive section and follow us from there. So without further ado, I'll let PK and Dr. Guja take over and let us know what's happening in there. Morning, PK. Morning, Dr. Guja.
Hey, good morning, Vishal. So, I'd like to welcome you to our lab here at Sinai, and I'd like to welcome Dr. Singla, Ray Lascano, our interventional NP, Dr. Guja, of course, and then Elizabeth, our nurse, and Damien Cabrera, our technician, for this really exciting and informative live case. Before we get started, I just want to tell you guys that our December live case will be on December the 6th. Because of the holidays, there's a lot of people taking vacations and such. So we will be having a live case a lot earlier than we normally do in December. So that, please, tune in and watch. It's going to be another exciting live case. Other things also, we're going to be transmitting live cases to Link in Leipzig this year again for the 4th year in a row. So those of you who are going to Leipzig, we'll see you live there. Or you can log on to the Link website and watch us live case from here in America. But without further ado, we're going to get started with this case. We're going to start with Dr. Singla giving us a quick overview of what we're going to do today.
Hey, Mark. So we have a 58-year-old man with a history of hypertension and significant smoking, 40-pack here. He quit about 10 years ago, and he presented at an outside hospital for evaluation of a severe bilateral lower extremity claudication, Rutherford category 3. He says he's unable to walk more than a couple of blocks, and it's been slowly progressive. His ABIs on the right side were 0.68, and the left ABI was 0.73. His blood pressure is 136/78 and a pulse of 64. Next. His labs were pretty within normal range. INR of 1.3, creat of 0.9, hemoglobin and platelets were within normal limits. Next. So these are the shots done a couple of weeks ago, and this is the inflow shot, which essentially shows occlusion on the right common iliac with the extensive collaterals from the lumbar collaterals, which fill through the right internal iliac. And there's a short segment of occlusion on the right side. And on the left side, it's about a 90% stenosis in the left common iliac segment. Next. This is the runoff on the left leg, which essentially shows the non-obstructive disease in the mid-SFA, and a 3-vessel runoff on the below knee segment. We did not have any pictures on the right leg at that time. Next.
So I want to go ahead and talk a little bit about what we've done so far today. So you can see here in the iliac angio that's performed today, you can see here that you've got distal aorta that's moderate atherosclerotic plaque with occlusion of the right common iliac right at the ostium. What's important to remember is I'm just going to step quickly on fluoro, and I want you guys to see the level of calcification. So you have heavy calcification here in the iliac, as you can see, and also the distal aorta is almost like a concrete block. So it's a heavily calcified iliac distal aorta. The other thing is the runoff on the right side also mimics pretty much what it's on the left side, with some moderate SFA disease and some really very good runoff down to the foot. Again, underfilled because of the occlusion, but doesn't really look like anything significant in the SFA or the tibials. So the entire case today is really talking about how to handle these type of iliac occlusions, and to talk about some of the pitfalls and some of the strategies that all of you can use at home to try to get through these cases early and without issue. So I just want to talk a little bit about to Dr. Kapoor. Dr. Kapoor, generally, what's your approach in this kind of iliac disease?
Well, like you rightly, you show in these cases, there's a lot of degree of calcification, and iliacs we always have to respect, because if we end up into trouble, they're not like the SFAs or below the knee, where we have a lot of room to wiggle. So in this case, I guess we have to, like you defined, probably take better angulated shots first to define the anatomy, define the reconstitution, if there's a microchannel, not a microchannel, and then the approach, like is it antegrade, retrograde, what, or both? So there are a lot of factors, I guess, to consider. I'm sure you're going to discuss it down the lane and, of course, show it as well. But my always concern in these iliac cases is, and of course, having vascular surgeons as backup always, or get their input in these cases. I mean, in this case, there's only a common iliac stenosis, so endovascularly the patient should do very well once we are successful and with no minimal disease. But like I said, there's also disease on the left common iliac, so it becomes very complicated as in how we start taking more images and start defining the anatomy, and that's where the decision making would come. So I think that's what I would see for now.
So as far as equipment, Dr. Guja, how would you approach this, and what's your approach to this particular case?
I think we standardly approach, I mean, this is a short segment CTO. I think this is more of how to handle the calcification of the iliacs. Reality is more important, but I would probably start off with an oven 4 confianza probably, just to try and see how it's going to take us. That might even cross this lesion. If the 014 confianza gives us a problem, I would probably switch to 018 and then probably an 035. But I would reserve the 035 here only because of the distal, a little bit of distal aortic disease. I don't want to extend any dissection plane going into the distal aorta, because I think this case, I think we might want to save the distal aortic stenting as much as possible.
Okay. Vishal, anything different equipment-wise that you would use?
I totally agree with Dr. Guja. I mean, I would take it a stepwise approach, start with 014 and slowly escalate up. And you can also see the lumbar artery on the right side is actually giving the collaterals all the way down to your, at the bifurcation of the common and the external. So, like you said, we want to try to keep it as much quote unquote intraluminal and try to avoid crossover stenting way up into the aorta. I'm sure we're going to discuss about types of stents and everything, but yeah.
So what are the so say this was occluded up to the ostium of the or the internal common bifurcation with preservation of the internal. Would that change your strategy in any way in terms of approach?
Well, I mean, the internal is the real lifeline in this case, because the internal would eventually give the collaterals down to your SFA and the profunda, and so we want to preserve the internal always.
No, but I mean in terms of interventionally, in terms of wires and stents and all that.
Yeah, I mean, this is calcified, so my primary thought process would be using covered stent. So if it's right at the bifurcation and if I can avoid covered stenting, I mean, stenting over the internal, that would be my primary goal. Or I could do is a focal self-expanding at the bifurcation and then do covered all the way up. Again, it all depends how we take it, but that's going to be a tricky.
So I think you bring up a lot of points. I think one of the issues that I've seen in a lot of operators is too much use of 035 wires in iliac lesions. I think you need to understand the pathophysiology of how iliac vessels close. You know, iliac vessels close by fenestrations, and from the coronary literature we've known that go with a hydrophilic wire and then do a wire, you know, escalation technique or whatever it may be called in the coronary vasculature. But here in the iliacs, I mean, what we've learned very much over the years is try to use, you know, a sharp tip, non-hydrophilic wire to be able to, first of all, penetrate the calcium, and then two is find the actual fenestrations. Crossing devices like the Crosshair have not been very successful in our hands. However, we checked the ACT list. Okay, and then so at the same time, I think that, you know, to go with an 035 wire is early on is probably difficult and will probably cause a higher rate of failure. One of the things also is to understand is that where we use the 035 wires is when we have a long segment occlusion of the iliacs. At that stage, we'll use the 035 wire to push up to the distal aorta just at the level of the junction, and then go ahead, switch out to an 014 to go and find the fenestration to go into the distal aorta. Second thing, I think very importantly, Vishal sort of pointed it out, but I think it's very, very important here, is that you need to look at when you look at your aortogram, you need to start studying as to what are the pitfalls and not. Obviously, the obvious one that everybody's going to pick out is calcium. So when you pick out the calcium, it's obvious that it's a high risk of perforation, so on and so forth. So that's one. It's a very important one because it's a life-threatening one. But beyond that, as far as the patients are concerned, is what's the status of the hypogastrics, especially when you have two lumbar collaterals here that are associated with this. Now if the lumbar collaterals are involved with the hypogastrics are occluded, then you can actually turn this patient into a severe buttock claudication if you use the lumbar. So if you lose the lumbar while you do the stenting, regardless of what type of stents you use, because I think that's a secondary conversation that we need to have. So it's important here to realize what's the status of your hypergastrics before you decide, okay? So it's important. It's not that hypergastrics can't be sacrificed or lumbars can't be sacrificed, but you need to understand what are the ramifications that this may have with the patient. After that, obviously, is crossing the lesion and anticoagulation and access. So what we've done here is we've used 2 bilateral 7 French access sheets. We've got our aortic rescue kit in the room if we need it. We've got covered stents in the room, and we'll talk about that after we cross it. So what our plan here is to go ahead with a 014 technique is, and we have an angle catheter called a aqua tempo catheter to see how this does. You can see here that obviously this is not a very simple calcified lesion. It's a very complex calcified lesion. Watch your knees, please. What you might have to do is angle out a little bit, then give a little bit of dye just to see where the collateral is for the lumbar and where it's going to enter. So there's not really a good view. So come out to the other side. Don't be afraid to really look at it in multiple views before you decide which way you want to cross the aorta. So this is kind of a better view. You're away from the lumbar, right? And then you want to just see whether you can just try to find that fenestration and just kind of pop it in here. Let's see, that may be dissection here. That's probably,
that looks better.
I don't know, I'm not too certain about that.
Doesn't look like it.
I don't know, the problem is with the 014 wire, you could be dissecting into aortic plaque and taking it up. You can see here how it's eccentric. So it's very important here to do multiple different views. You see that?
Yep.
So I think that's very important for the audience to remember that, this is, you'll start to see how the wire plays before you decide, and then decide how it goes here.
That's more like
So we'll see.
That's better.
Sometimes it's so calcified it just doesn't work.
So this is your confianza wire right now?
This is just a give me a little torquer here, guys. This is just a simple confianza wire trying to get through the aortic plaque here. A lot of times you just have to play with it a little bit, maybe a little torquer, and then try to find a different lumen, a different area here of trying to, get through. Nope, that's the same area there.
That's the same one right there.
That looks more like
Looks.
that looks more promising.
But you see, it should be in right about here. You can see by the injection. See?
It looks more promising, no?
Looks a little more promising. And it's just sort of playing with it. And sometimes you can torque your catheter here, try to find a different lesion. Still finding that point.
Yeah, I guess the issue in this case is because it's a blunt stump, you might end up subintimal and re-enter into a slightly above in the aorta.
Which is the
right
problem, which is what you'd like to avoid here.
Right, correct.
And sometimes it means that maybe are you subintimal from below. So a lot of times what I do is in this kind of situation, after playing a little bit, is to take a little dye in a syringe and inject from below, because it gives you an idea of how how this is going to work. So what we're going to do is we're just going to go ahead and inject from below. It's going to give us an idea of which track to take, and then give you a better idea of what to do here. So we're going to pull the catheter back, right? I'm going to withdraw a little bit, because remember, you might be in a false channel to begin with. So you have a lot of collaterals and fenestrations.
You remember?
And so, no, we'll do it this way, and then we'll go ahead and take a shot here. Okay, so what I'm going to do here is I'm just going to track this up. Just track it up to this spot, right? Just use the catheter. Don't be afraid to push the blunt catheter dissection here. Try to free it up a little bit here. There it goes. Right, and then turn it again. There you go.
There it
into
is.
that, right? And then now inject a little bit. See,
So
now
you're actually seeing the flow back in favor.
let's go ahead and take another picture here.
So, PK, the lumbar seem like they're coming right off from the occlusion area, but I think the right side lumbar makes a big tortuous bend. I think it comes up a little bit way higher than.
Okay, so this is the spot. So now you've confirmed the spot. You like the spot. Now I'm going to make now you might need a different sort of wire. This may not be strong enough.
Yeah, maybe a little heavier wire.
Let's try a couple of times more and then decide. Sometimes these short lesions you get impatient, and then when you get impatient, you just make mistakes. Just be patient with it and try to see whether it'll pop through for you.
So so for anticoagulation, do you fully anticoagulate? Do you keep your ACT on the lower side? So what's
Well,
your
generally, in a live case, we tend to anticoagulate a little more aggressively because we know we're going to be talking a lot. But in a normal, if this was just a regular day in the cath lab, I think our anticoagulation strategy would be a little bit different here. I think we probably would have either not anticoagulated or given very little anticoagulation because we're just going to be working and we're going to be working really, really fast. These iliac vessels are so large that I think that the issue here is just that we're just, no, it's not going. Are so large that I think the flow is so good that the chances of us actually, thrombosing is very low. Give me a connect wire, please. Connect 250T. So now we're going to upgrade our, well, actually, you know what? Give me a Terumo M wire. Give me a Terumo M wire. So we're going to go with a little bit of a hydrophilic wire here, which is going to create a small channel, the Terumo M, and see whether we can pop through. I mean, worst comes to worst here, if we have to go to a glide, it'll be the last step that we will do. And in this case, if that's what it takes, it's what it takes. But the initial strategy for a lot of people will be, let me just go with the glide wire. And I think that you may be lucky, you may pop right in, or like Dr. Gu just said, you may just dissect all the way down into the side of the aorta and make your case a little bit more difficult. But remember, the point is he's a claudicant, and I think you need to understand that there are always things that he can have to make his claudication symptoms better, So I think it's important that we also are very cognizant of the fact that he is a claudicant and that he is not an ischemic threatened limb, So, and this is the aorta, and there are things that we can do. This is acting like really calcified, as you can see. See that? It's really bouncing back to the other side. So this is really, really either in plaques. Let me just pull back a little bit. That's not what I want. That's in the collateral. And that's what you got to watch too. Are we seeing something in a fenestration? Can you push the catheter up slightly? Thank you. Are we just seeing something fenestration-wise that's creating this? No, it's not going. All right, give me the connect now. Might have to go with a glide here, boys, which is funny because we thought we wouldn't.
Yeah. Like you rightly said, sometimes these short lesions, even though they look short and sweet, they're not that.
They're not that sweet.
They're not that sweet.
Very calcified, right? So
yeah,
calcified iliac CTOs always become tough. They're unexpected.
The other thing you could use the 018, what is that wire, guys? The Gaia.
Gaia.
You can try the Gaia because it has a pre-made tip, and it really is good for finding fenestrations. So maybe we'll switch to that before we go to the other wire.
Looks like a good tip.
Yeah, just put a little tip there. A little bit bigger than a normal coronary CTO tip. I mean, this is the part where it's sort of like watching paint dry. So Vishal, why don't you talk a little bit about your approach to taking care of these patients after we cross, if we cross? What do you think are the chances? Torka, please.
Well, I mean, in this case, hopefully we should be able to cross if you're in, I guess.
Let's talk about a strategy first. Okay, you don't cross. How do you treat this patient? You do cross. How do you treat this patient?
So if I don't cross, I would just probably continue my conservative medical therapy, which is exercise, Pletal, and all the real things. Because like you said, you still have the internal and the lumbar supplying it down. I know it's lifestyle limiting, but sometimes continuing, and it's a claudicant, so I would still keep continuing conservative therapy and probably bring him back another day for a reattempt. Would I send this patient really for primary surgery? I'm not a big fan, especially for a claudicant, and I would probably give it one more attempt before we start looking into that aspect. That's again my personal, is it based on data? No, it's more of a personal experience. And if we cross in this case, and hopefully we would,
feel free.
Then I would probably start thinking about more being calcification and using covered stents as my primary goal strategy.
So the other thing here, Vishal, looks like we crossed with,
What?
Oh, sorry.
You pull?
Yeah, Dr. Guja decided to do a Farhan Majid.
Oh. Yeah. Well, maybe we should get Farhan to come and defend himself.
No.
This one.
I'm just teasing. The rule is if you cross once, you can always cross again, right? And Karthik always says that to me all the time. He goes, what are you worried about? Every time you cross, you can cross again. Try to torque that a little bit, Karthik.
I think you're fine.
Or take it higher for me. Let's see whether we can interact at some point with this catheter before we take our Looks
pretty free.
really
Looks
free
good.
there.
That looks
yeah.
free now.
A little bit higher. Wait, what is he saying, Liz?
No, it's okay.
Liz, anything? Yep, I think that's good. That's pretty good. I think we're in. You wanna
put the wire up?
Well, you know, the other thing also here is to see whether we can also interact. Show me the catheter again. This is almost impossible, but we'll try the impossible. Push it up here. Let's see whether we can just try to, put it in.
Externalize the wire.
That'll be all right.
I just want to interact a little bit.
This is aorta.
This is aorta. It's impossible.
It's difficult.
I don't know. I think we're pretty in, right? Agreed,
Looks
everyone? Yeah, it looks very promising.
Okay.
All right, now Dr. Guj is going to go in here with the catheter. Let's see if it goes. A little more? No. Okay. All right, give me a...
What I would do is to exchange for an 014 and 018 micro.
Oh, what happened?
You okay? Sharp pain through. Just take an 014.
Give me
Yeah,
an
give
018.
it 014, 018 Trailblazer.
Give me an 018 Trailblazer, guys, Flora. You got it?
Yeah.
It looks promising though, but yeah.
Yeah, I have it.
So let's take an 018 Trailblazer across, and then give me a V18 wire.
Vishal, you just saw him, right? He was so sensitive even with a little bit of pushing.
Yeah, I think that's
how
your re-entry
calcified
point
the
right
iliac
there.
is, right? So it tells you how difficult these cases can be.
Flush, right?
Yeah, this case is a little bit more tricky because, like you said,
Be careful, careful.
the carina, the bifurcation, everything has to be taken care of and considered. So
Look like so.
Let me see, let me see. He's feeling it. He's feeling it a little more, Vishal, here. Yeah, I don't think we're in. No.
it's on the lateral wall. you
Yeah,
think?
we're not in. Okay. Give me an 035 wire. Give me an 035 catheter again. He was having a lot of pain. Give me back this one. Give me the V18 now. Give me the 035 catheter. Yeah, I wouldn't go up without a wire.
Yeah.
Without a catheter. So a lot of times it's important to communicate with the patient, see what's going on.
Yeah, that's a very good observation, I guess, from a clinical perspective to watch for the
Just pull
patient,
this out
his
for a second.
symptoms,
Okay.
and
pull.
see how they do.
Yeah.
Because
I'm going to actually withdraw this wire right now. Rail, please don't let the wire go forward. Pull the wire back. So I'm just going to pull the wire back. I'm going to go up to this level here.
start a little bit lower.
I'm going to
and then-
start a little bit lower with a V18 this time. Are you better now? Oh, okay, good. So remember, a lot of times you can get subintimal into the aortic plaque. Give me a torque around this, guys. And that may also cause that. But I know we were in before Farhan pulled it out. So, so if we can get in once, we can get in twice, right?
Yeah.
That's not it. That's for sure. Let me torque the
More
other
on
way.
the medial. Yeah. no.
Worst.
No, that's not it. Okay, now let's flag up. Little die, guys?
That looks a little bit better.
Yeah, it looks a little better. We're more center luminal here.
Yeah. Yeah, I
Yeah.
think that's a.
Let me just see if I can get this catheter up a little more. There it is. Give me a torquer now. Yeah.
That's
Yeah.
a cap, huh?
Breaking into that cap is, I guess, the biggest T right now.
No.
Oh, no,
not
so-
that, not that.
There. Right there.
Track the catheter up. No.
No. Whatever you were before is good.
Yeah, but I think you got to stop. Yeah, don't push as much.
Yeah.
Yep, give me an 035 wire here. I think here we got no choice. I think angle.
Angles.
Let's get a torque around this one too.
Yeah, these calcified lesions are very, very tricky with these open 4 wires. I remember we were talking with
Well,
me
you
and
know,
Karthik.
it's worked really well in our. Thank you, Karthik.
Right.
It's
No,
worked-
I know. I agree. Like we talked, like me and Karthik were doing this case last 2 days ago, where a wire actually got stuck in the iliac. There was another iliac CTO case, and it was very interesting. So you're right. We just have to be careful that.
You have to be
calcification-
careful.
You just have to be patient. There's no reason to rush. Just have to be patient. It will cross.
No.
Not that.
Sir? Are you okay?
Not that. Not that. Not that.
What's his?
No,
Not
that's
that. Not that.
You know what? Let's give a little dive from below. Syringe, right? The back. You can have some injectable dye in the back, please. Give me a roadmap here, Ray. Let's inject from above and below, guys. Pull this back. One second, not yet.
Inject.
Not yet. Ready? When I tell you. Inject. Okay. Okay, let's try.
Yeah.
This looks more
I
better.
think
no?
this is probably a better approach right here.
Right there. Right there.
Okay.
I'll take out.
Mm-hmm. So what are the options, Vishal? You didn't tell me what are the options. Can I have this? So, what are the options if we fail, brother? What would you do, Karthik, if this doesn't go through for this patient? Would you just leave him with medical therapy?
I would.
For this patient, I would probably stent the left. I mean, clearly the left side, right?
Right.
And I would probably try medical therapy. Stenting the left side might give you more collateral flow from bilateral internal iliacs,
Right.
and give him more therapy. But if this fails, again, if you think that
No.
that's probably what my first step is. But if he keeps on having claudication, then we can stent this iliac and send him for a fem-fem.
Yep.
That's probably the most or the
Right.
easiest way to do it, because you can give one side flow and then fem-fem will take care of it.
I mean, yeah, he has very good outflow on the right leg. So I guess
Yeah.
I would probably bring him, if worst case we're not able to cross, probably bring him back another 6 to 8 weeks, reattempt it.
And reattempt it.
And then if we fail again, of course, we have an option, like Karthik said, to do a fem-fem bypass and have an excellent flow, because he has good, I think, 3 vessel flow, downflow on the right side. So he should do very well on a fem-fem, which is more not retroperitoneal. So we just off the vasculature right there. So, but
No.
It's just bouncing off that calcium. Ready from above?
Yeah, not bro.
Yeah, I see the nub. Maybe try from above now. See? Pull back a little. Let's try to cross the other side here. Let's try to go this way.
I know it sounds a little. Do you want to do a little bit of cranial shot to lift those
That's
lumbars
enough.
off?
That's
So
enough.
maybe you could see some entry point.
Maybe.
Just another view, like you said, you do multiple views. I think a little bit of cranial.
You can
will-
see that calcium in that nub peak, right
No,
there.
I understand.
See that? That's
I'm just trying to connect the two knobs. Maybe there is something we could
Yep, let's try this shot here.
just.
I don't know if that's a nub.
Yeah, that's what it is. I just wanted to see, take the lumbars off your view.
Pull
So
the
that way.
catheter up. It's going into the
It's
other
pretty
one.
much like connecting the two dots. It's like.
Nope.
Yeah.
But still no.
I think that's where it went the
still no.
first time.
that's still not.
Yeah, but the wire's not moving. See? No. No.
That's
way.
not. That's not. That's not. That's not. The direction. It should be really free.
All right, let's try from maybe from above, huh?
Are you okay, Horace?
What's his EF card?
EGF is normal.
Just
This is not easy. So what do you think
Yeah.
as far as treatment is concerned here, Chief? Okay, oops. Now give me back that confiance.
I know, I was going to say, it might sound counterintuitive, but do you want to step back on your 035 and go back to an
Yep,
014?
I agree, because I think we've created so many planes here.
Yeah.
This seems so encouraging,
No,
but
it's
it's
that
not.
spiral. Maybe like an Astado or a Vin, something might.
Yes, I think Confianza may be good here.
Okay, yeah, I mean, what I mean to say is any 014s might help us.
See, right there is the cap, and then it seems to want to go somewhere else. See, then it goes into this side. Okay, let's try. Give me some more direct. Confianza. Let's try again. So, Vishal,
Yeah.
if you had to come from above, what would you do?
But here it's going to be from above, then we probably have to get a brachial access to give us better pushability. Here we have nothing to connect or nothing to hook into.
A
So
little bit when the wire gets.
it'll be very tricky
Yeah, right
to
there.
try to really cross it with no
Right there, I
pushability
think,
from the
right?
contralateral side.
I mean, that spot is not working, so we got to try something different. So let's try here. Let's
Yeah,
take
I
it
think
this
it'll come
way.
back a little bit. And
That's
then,
what I did. I pulled the catheter back and said maybe we're coming from another angle here. It was going to help us a little bit more. So, you know, it's important. So let's talk a little bit about definitive therapy for calcified iliacs. Well, what does the data show? What do you guys feel for iliac stenting, so on and so forth?
Well, I mean, iliac stenting, most likely, I mean, all the data is from mainly essentially the COBUS trial, which is the covered stent they use and proved that the covered stents work great. So in these kind of cases where there's a lot of calcification, my primary goal is always will be a covered stenting. And like we talked about the involvement of the internal iliacs and the lumbars, in this case, because the contralateral internal
There
iliac is
you
still
go.
patent.
That is, see this, guys, this is
Yes.
in now. You see this? So that's kind of what you have to do. Let's just
You wanna move it a
make
little
sure
bit
that I'm going
Just
to.
make sure, it
This
looks
is
very promising.
No, wait, hold on. Let me just try to. Yep. This is in. Now I'm more than convinced it's in. So now we need an 018 catheter.
Want to push it up?
Yep. I'm just going to try to go up slowly.
So I guess this is a great, yeah, see now it's all art, you see it's going all plain perfect.
There you go. It's just aortic plaque it's interacting with. Okay, good. So now we're going to walk this out. So remember that, you know, it's just a little bit of patience, like Dr. Gu just said. Stick with a little bit of patience. Now we're going to get a V18 in there.
It's very rare that I mean only isolated common iliac CTO cannot be crossed. So
No, but I guess the biggest take point in this case is trying to step back from an 035 going, I know it sounds, like I said, counterintuitive to go from all the way from 035 back to 014, but the 014 wire gives you a little bit more, finding more luminal channels in these cases where they're short. So I think it was a great idea, and like we suggested, to go back to the 014 system and try to poke around. So you just probably have to step back and start from scratch, but it definitely works like we proved in this case. So
As long as the ghost of Farhan Majid doesn't appear, we're okay.
good.
Dr. Guj and I have very fond memories of Dr. Majid.
But at least,
Is he on vacation?
at least,
you know, this tells you how much he exploits his fellows.
Oh,
I have been a part of that exploitation.
Let me back up. Hold on.
well, we still remember that link case when me and Guja were blamed for pulling the filter off, and I still remember that part.
What happened?
All right.
I think we're good in that. Just
Okay, now we're going to go through with the
Michael.
018 catheter here. I know.
Yeah.
Get us now a.
It's gonna go
There
right
it
there.
goes. It's called a little bit of love. Okay, wait. Watch the confianza now. You got to watch. You got to be very careful when you pop through. Yeah. Okay, good. Excellent. Now let's check a pressure. So right now we have an 018 hole in the aorta, right? So if we're subintimal, it's okay. You can always reverse anticoagulation. So you want to check pressure, right? So now here's your, Dr. Guj is going to pull back. Let me pull back and make sure we have pressure here. Yep, of course we don't have any blood flow. Or maybe it's
It's
collapsed.
moving with the. Yeah, it's actually moving with the pulsation.
Yeah, I know, but here it comes.
Patience.
So we definitely have blood flow.
Sweet.
It's a small catheter, guys, so understand that this is going to be, give me a flush ray. Yeah, 5 cc flush.
Beautiful.
So we definitely have blood flow. Looks like arterial blood. Just going to flush this through.
Think you get a pressure?
Yeah, we should get a pressure. There it is.
There you go.
There's our, show the pressure tracing, guys. So there's our aortic pressure. So
Oh,
now
beautiful.
you know, now this is aorta, right? And
Yeah.
this is our catheter. So there's aortic pressure. Now you know you're in the aorta. So now you can feel confident putting your 018 V18. So what you want to do is make a big C curve.
You know, Vishal, I think this is a great demonstration of how it should actually be done without causing complications or without causing any more further dissections into the aorta. Because a little bit more dissection in the aorta changes the whole plan for this patient. Now we are talking about distal aortic stenting versus creating an arms, moving from regular covered stents in
Now
iliacs to
give
an
me
endograft.
a Terumo Navicross, please. I'm sorry to interrupt. Yep, go ahead, Karthik. It's great points. Show me both.
Yeah, you're going to an endograft level. When you put an endograft, I mean, it might not be significant mortality increase, but morbidity increase, yes, might be. So I think everybody has to keep in mind. That
So get the wire up into the ascending
Arch.
aorta, right? And now you know that, or the descending aorta, you want to show that you're in the arch. There you go, you're in the arch. But keep it in the descending aorta. And then you go ahead and now you're going to go switch out. Now what you need is, before you do anything, this is very important, guys. So Ray's going to now put an 035 supercore through the other side. Actually, you know what? Maybe not. Let's wait. I'll tell you what I was suggesting that is because I wasn't sure where we had crossed, but I think here we're okay. I'm very certain we're doing well. I'm just going to take a picture just to see where we're at. Here it is. Ready? I want to see how this wire went through. And you can see it's very, very favorable, right? And I'm
Right.
going to go get that collateral off a little bit here.
you want to
And then take a look
you want to
here.
go Quadral and see.
Yeah, a little bit, yeah. See, we're off the collateral, right? We'll try the other view as well to show in 3 different views how we crossed. See that? Very, very favorable cross. So now we're going to get a Terumo Navi cross, and then we're going to now put up a stiff wire called the supercore wire, right?
All right, I guess now since we've crossed, we probably could talk about your stenting strategy, more so of how far up do you really want to go, and how do you want to approach this with the lesion on the left side?
How would you do it, Vishal?
Well, so I guess in this case, like you rightly said, we have to do a stenting of both the left and the right, because once we stent the right side, it's going to affect the left carina, and the left also has disease.
There you go.
The question really arises is how far up do you want to go? In this case, because it was a stump blunt, I would want to cover it and probably keep a couple
You're
of
gonna have
stent
to
struts up
jimmy
into
it
the
through.
aorta. So I might end up so-called compromising the natural carina and then stent it
Now give
with
us
the
the
covered
supercore.
stent all the way up. It'll be hard to get an ideal V stenting with not being able to spare the normal segment. So that would probably be my strategy in this case. How about you, Karthik?
Yes, same thing, Vishal. I would try to avoid stenting anything into the aorta here, especially because of that lumbar collateral. I mean, I think the collateral from the left side is a little bit higher on, but the right side collateral is definitely a little bit lower. But I think it's making a big bend, so I think we should be pretty safe doing a V stenting.
All right.
My goal is always to
Get
spare
a-
the aorta in any kind of iliac stenting as much as possible, because that complicates things a
60/40,
little bit. And then now you're talking about endoleak sites and everything. So
I think what's very important to understand is that the covered stents give you a false sense of security. You know, that's the first thing I
That's
think the
right.
audience has to understand. Sorry about that. Covered stents give you a false sense of security, because no matter what, an endograft is probably your best and safest way
Right.
to deal with most lesions, because you have a proximal seal and a distal seal. The major reason for the covered stents is that the covered stents, or not all, and I want to say this categorically, not all covered stents are created equal. You know, this is not a sponsored program by any particular company, And I'll go on record in saying that, the Gore VBX that just came out recently is a phenomenal covered stent. Now let me explain why all covered stents are not created equal. Well, as you know, when you go in these type of complex lesions from distal aorta to common iliac, again, I'm not Jim McKinsey, I'm not a aortic aneurysm specialist, but I'm sure Jim would agree with me, knowing him, that you have this size mismatches between the aorta or common iliac and common iliac or external iliac. You can go ahead, you can go in, but just don't cross. So therefore, I think it's very important to understand that when you have size mismatches, you might need to expand one of the stents to a larger level, one of the stents to a smaller level. So the Gore this particular stent, which is phenomenal, the VBX stent, comes in multiple different sizes. But the beauty of it is the stent can actually be expanded from a 7 to an 11. Okay, and hold on a second, and an 8 to an 11, and the 9 and 10s can go through 13s. Now, I mean, there's patency data, this and that. We can talk about that in a second. The primary patency in the VBS Flex study, it's a single-arm study. I believe it wasn't randomized, right? As far as I remember, wasn't randomized.
Yeah.
And so basically, it showed ultrasound-derived patency and TAS C and D lesions were on 96.7% at 9 months and 94% at 12 months. Now, guys, I mean, I'm impressed, and it's great, but iliac stents stay open. Whether you're going to do a VBX or a Vibon, or if you're going to do even a Bravissimo, which showed the Abbott balloon expandable stent, also stayed open, TAS C and D, at 1 year in the 90s. So the point is, it's not about the patency. I think the patency is phenomenal in most iliac stents. Interestingly, balloon expandable versus self-expanding is another discussion we could have, but clearly the VBX advantage is that you can actually taper it to a difficult lesion such as this, into the distal aorta or into a dilated common iliac, external iliac junction. So you can basically dilate a part, even selectively a part of the stent. You can dilate the proximal edge of the stent to 11, and then keep the distal edge of the stent at a 7, 8, with minimal foreshortening. So you can almost tailor your stent to your lesion. That's important to remember. Second, deliverability. Up to, I believe, an 8, and they're going to correct me if I'm wrong with a head nod, goes through a 7 French sheath. Okay, up to an 8 goes through a 7 French sheath. 9 and 10, obviously the largest size is 58s. I think at 7 and at 8 needs 8 French sheath. Right. Other than up to a 38 can go through a 7 French sheath, if I remember right. So important things, is very flexible, phenomenal stent, important. Second thing, let's throw out the myth here. You are not going to get away without stenting the aorta here. Correct. You have an ostial flush occlusion. Distal aorta is heavily diseased. You're going to have to extend your stents into the aorta. So remember, you cannot have this false sense of security that the VBX or any stent is going to give you a great aortic seal. It's not. If you're worried about aortic rupture, you need to go with an endograph, period. Whether you decide to go with an endologic therapy or a Gore endograph, it doesn't really matter. That's your flavor. You select what you want. But what I'm trying to tell you is throw out the myth that the VBX, once you put a VBX or any covered stent in, you've got a seal and you're safe. It's not true. So you always have to be cognizant of the fact here that aortic rupture is a reality, and you have to be very careful. Number two, the lumbar collaterals are likely going to be sacrificed in this case. What's my ACT list? Okay, so the ACT is down to 200, which I'm actually happy with. So now we're going to go ahead. Karthik is going to cross this. So the lumbar collaterals are going to be crossed. That's why the patency of the internal iliacs is that important. So let's see whether this goes. And of course, it's not going to go. There it goes. Karthik jimmied it through. There it is. Beautiful. Let's stop there. Pull down a little bit, Karthik. Yeah. Okay. And at this stage, Liz gave a little bit more heparin. Now we're going to dilate. So when we dilate this lesion, we go undersized with the balloon. We're at a 6 millimeter balloon here, which is probably very undersized for this lesion. And obviously, we're going to watch for all the parameters, pain, pallor, what is it called? Bradycardia. I think you're not deep enough, but that's okay. Let's dilate this first. Maybe you are, right? Yeah, I am. So we dilate this to 8 atmospheres, very easily dilated. No pain, no bradycardia, no nothing.
But look at the eccentricity of that balloon.
So now what I'm going to do is when I go down with the balloon, I'm going to leave it there. I'm going to see for the change in my pressure and the aortic pressure. Show me the pressure, please. Sheet to the thing. There's no change. So you have to go up with the balloon a little bit more. Okay. Let's dilate again. Okay, there's another dilatation, right? And that looks really good, right there. Yep. Right? So again, I'm going to go to 8. Okay. And I'm going to come down. Okay, now you're going to see a little bit of an improvement in pressure here in a second. much better improvement in pressure, right? So now I'm going to withdraw back, just make sure I don't have any clots. I'm going to have Dr. Guja now walk the balloon, or I'm going to walk the balloon back while we're going to take a picture. As we walk the balloon back, we're just going to watch the aortic. Sarah, don't move! We're going to watch the aortic pressure.
Oh, look, it's coming up right there.
Ready? Yep, we're just going to take a picture just to see how our flow is. There's our
Nice.
flow, right? Beautiful flow. So which is which now? Yellow is the
Yellow is the
so
iliac
so you
side.
notice that our manifold still shows
Give me,
the pressure is not fully equal to the aorta.
Okay.
Does he have distal external iliac
Just try
disease?
not to move, okay?
There might be some, yeah, there might be some disease.
There
down
might be
the
some.
same-
So now now what we're going to do is we're going to go ahead. I'm going to put this. I'm going to freeze this. I'm going to go with I may actually go with another 6 on the opposite side. So Dr. Guja's IVUS this opposite side. How much was it, Karthik?
8.7.
So it was 8.7 in diameter. So we're probably going to go with a 8 VBX, and then we're going to decide after the 8 VBX on what we're going to take it up to. So let's come down here. Let's walk this other. Give him a supercore on the other side. So I put him on this one. So now when we go on to this pressure, I'm going to have them cycle a cuff so I see what my aortic pressure is. Sir, don't move, sir. Aortic pressure is. Give me a new 6 balloon on the opposite side, guys.
So are you going to switch your UF catheter now to the right side for better visualization of the left side, or you're just going to engage?
I think we have 7 French sheet, Vishal. We should be able to inject through.
Or going all the way up, it sometimes, unless you have a long 725 all the way
Well,
up.
you know, of course. I mean, when you do these cases, I can pull down and push it out. Okay, good. Should be no resistance on the balloon.
Nothing.
Like on the wire. Okay, we're going to walk this out. So now we're going to go ahead. And now we're going to put a 6-0 on this side. Now the other thing we could do, Vishal, is actually go ahead and track your contralateral sheath across the lesion
Right.
to have access, which is what I may do here. Fix the wire, please, here.
1 second. 1 second.
Come on this side, Karthik. Fix the wire. I want to show everybody
One second,
what you can do here. Fix that wire in the
1
balloon.
second. Just take it.
Flora, fix the wire in the balloon on this side. Yeah.
I did.
So what do you, Flora, please? So what you want to do now?
So you don't have.
Flora, please.
Remember,
It's
okay,
okay.
the balloon is not.
Yeah, you have to put
No,
the.
no, I'm going to push the balloon across. I'm going to push the balloon here. I'm going to take the sheet. So I'm going to take the sheet up. So there's the sheet. And I'm just going to sheet the balloon. You see this here?
Nice.
So this is called sheathing the balloon. So now what I have is, now I have access into the aorta. Now I have an aortic pressure and I can inject. Walk out. You can leave the balloon or walk it out. It's up to you. I'd walk it out now. So we're going to walk out the balloon.
Yeah, that's a great technique.
Well, it's an important technique, right?
Very
So
good.
when they walk out the balloon now we're going to go with the contralateral iliac. Give me the 6-0 balloon, please. So we're going to go with the same 6-0 balloon because Dr. Gujo believes in no wastage. And we're going to go right in and we're going to go ahead and take a picture. Rail, please, quick.
The presidential elections have
Flora?
been dependent on healthcare costs, so
Flora?
I think we should worry about it.
Flora? Not you, sir. Flora?
If the presidents are worrying about it, I think we should worry about it too. Do you agree, Vishal?
I agree
Okay, let's
with
go
you, my
slowly
friend.
here, guys. So remember, guys, the 2 things I want you to be careful about, sometimes you can get bit in the ass. I'll tell you why. Because, I mean, remember, that's another name for a donkey. So remember that one of the things you want to watch out for is, see the eccentric expansion of the balloon here?
Yes.
Because of the eccentric calcium, be careful. Because you could do the tough case well, and then you could rupture the contralateral iliac and be in trouble. So that's why I'm telling you to be careful here. So
Agreed.
right now, Dr. Guja is inflating the balloon to 6. Okay? And then now notice that expansion of the balloon. And this is where the eccentric calcium is actually more dangerous for you than
Than
having
CTO.
calcium that's concentric. Although concentric calcium is by every definition of severe calcium a difficult calcium to deal with. Down. So now what I want you to do is go on DSA, watch the pressure as the balloon comes down, right? The pressure is still solid. And then I'm going to go ahead now and take a picture. Ready? Ready, Chief? You can inject through this. You can inject through this. Oh, it's not hooked here? No, it's hooked here.
No, this is.
Yeah.
Wait, wait, wait.
Flush forward, please. Okay. So pressures are very good right now. So always keep the balloon up in that spot for you. And then you can see the pressures have almost normalized, which is fine.
Correct.
So now I'm going to inject through the sheath in the aorta, right? Dr. Aguja is going to inject with this one. Okay, inject.
Okay,
Again, we'll do a better injection in a second. Ready?
Okay.
Okay, no evidence of real extravasation. So now what I'm going to do is I'm going to take this sheath up into the aorta, right? Do the same thing we talked about. Not going.
Iliac is moving.
There's still that eccentric calcium.
All right, walk this out now. Let's take a picture through this sheet now. Leave the balloon in the sheet. Ready to inject?
Yeah,
nothing bad, nothing horrible. All right, so now the option would be just to go ahead, go with 2 VBXs and be done with it. So since I can take my 7 to 11s, I'm going to go with a 7058 VBX. Now, important guys, we talked about the internal iliac in relation with the common, with the common. We're going to lose those hypergastrics more than likely. So let's go to the aortogram now.
Why are you going with the 50s?
Let's see, maybe 38s. I'm not sure.
We can't go with 28 or 38s?
I
No, I
think
think with
38.
7038, you can always take it up to 11. Give me 2 7038s instead.
But they
Yeah.
foreshorten a lot, no?
No, they don't. They foreshorten very little. That's the beauty. Give me two 7038s. I think the right side you're going to need a 58, right? What size was that balloon, guys? 40. That was a 40. Okay. So give me 2 7038s. So walk this out. So we're going to go with 2 7038s.
You always need, most likely you just need one internal iliac. As long as you have one good internal iliac.
Exactly.
The right side is more important, and the left side is more important here because the left side internal iliac looks disease-free when compared to the right side.
So remember,
Really
I have the ability here to go up to 11 millimeter stents if I want to. So
And what's the degree of foreshortening do you expect from these?
very little, very little. I would say 2 to 3 millimeters when it goes up to 11, right? 730 will become like a 730, what, 31, 32?
Every 1 millimeter past nominal is 2.5 millimeters.
So every 1 millimeter past nominal, use 2.5 millimeters. So if a 7 goes to 11, that's 4, so you lose about 8 millimeters. So a 38 becomes a 30 or a 29, which is reasonable. Which we're not going to go to 11 here anyway. So we know that. That's why I took a 7. So I also took a 7 here to be a little bit more comfortable because I know I can go up further with this particular stent. Maybe he has pain at 7 at nominal, and I reduce my gradient to 0. I don't need to go up any further. Remember, guys, iliac is a disease of gradient. It's not a disease of how it looks.
Correct.
You know, as vascular surgeons, they've known this for a long time. The interventional cardiologists, due to our mostly poor training in vascular, don't understand that. And it's very, very important to realize that it's mostly gradients. Okay, so don't worry about how it looks. You know, in the coronaries, a non-expanded stent has a high risk of restenosis and thrombosis. In the peripheral, in the iliac, that's absolutely not true. So therefore, understand that and be confident with once you abolish the gradient to leave that. The only place where you know that your placement of your stent is very, very important and has been documented is in the renals, right? When you have renal stents, 1-to-1 deployment has been shown to increase patency. Greater than 1-to-1 has been shown to reduce what is it called the patency. And I mean, greater than 1-to-1 has been shown to increase rupture, and less than 1-to-1 has been shown to reduce patency. So give me another one here. So remember, right, before I go in now, I'm just going to take a picture on this side here, Karthik. So I just want to see where we are. Ready? Inject. It's okay. So we know we got a way to come back, right? So why doesn't Karthik place this stent first? Okay. So keep pulling. No, you can just walk it out from there. Why are you pulling from here? I'm just going to pull the sheet back as you come back. There you go. Okay.
A little bit more.
Okay, that should be good right there. Like kind of like that. Here.
Pull the sheet back.
Yep. Let's inject from the bottom of the sheet here, guys. Actually, you know what? Let's inject from above. Give me a really good injection, guys. There you go. That's perfect. Okay. So I would actually go up a little more in the stent, right about there. Okay. Now give me this one. Sorry, we'll take a picture at the end.
You can inject through the sheet, so it should be okay.
That's another reason I went with a 7.
Yeah.
Right? So it gives you a lot of advantages in what you're doing, guys and gals. Liz always corrects me. By the way, let's say a good morning to Mary Chu. She's late. Getting in slowly. I know she's not late.
She's actually not here.
You ready for a picture on both sides? I think we have to go up, but I'll tell you in a second. Nope. Ready? Mm-hmm.
You can pull back.
Nope. I kind of like it, don't you?
No, I can pull back.
So is your strategy of going up together, one at a time, left first, right first? How do you choose?
You have to go up together. Let's take another picture here, guys. Look at our pressures now. Inject. Inject.
Probably needed a longer on the right side. Yes.
Yeah, probably longer, but I think we could always put a second
Yeah,
stent.
no, of
I'm worried
course.
about my. See, am I across my internal there? No, right?
No.
I'm not.
No, you didn't.
So you could probably use
What's important here is to get into the aorta and make sure you're in the aorta. So I don't mind putting a second stent. I just want to make sure I'm in the aorta. I kind of like this right here, right?
Yeah, I think that's
this is
better.
a very good spot here. Let's go up together here, guys.
You want to take a DSA picture?
Okay, it doesn't. Okay, let's take a DSA picture, sir.
One sec.
Cyclocuffless. Okay. Sir, hold your breath for me. Go ahead.
Go ahead.
That's perfect. Agreed? You're going to have to be across those lumbars.
Yeah, no, you have to
Yeah,
do that.
ready?
Yeah. Hold on 1 second. Let's look.
We're going
I would
to,
come
well,
down and
cyclocuff. No, I wouldn't come down because your lumbars are right at the occlusion.
Yeah.
Let's-
Both the sheets are
Yep,
away from
distal.
them.
Ready? Go up, guys?
You can still come down a little bit more.
No, I know, but we could always put another stent.
No, I'm saying you can. No, not. I'm not worried about the distal. I'm worried about the ostium of the.
Blood pressure is 110. Oh, breathe. Come on, guys. Let's go up here. Go up together. What's nominal?
12.
Okay, go up. What was his opening blood pressure by cuff?
Go ahead.
Okay. It's got some play. Just give it.
Go.
Just slowly. Uh-huh.
So here you just have to go slow to
Mhm.
let it expand, let it take its breath and time.
Mm-hmm.
6,
7,
Very nice.
9,
10.
10, 11, 12. You're at 12 boat?
Yeah.
Okay, down. Okay. Okay, there you go. Pressure's
Beautiful.
coming back up. Good. Left side is completely relieved like I'd expect. So now let's take a picture through the sheets. Ready? Ready to inject?
1 sec.
Okay.
DSA?
Yep, in a second.
Yeah.
Very nice.
Very nice. All right, so now we can post dilate these with 8s. Okay, give me
You
two
could
80.
cover a little bit more on,
Hmm?
on this side.
No, we're going to come down below. So give me 8040s.
This side is fine.
Actually, 8020s is
I
fine.
think this side is okay.
Yeah, but I think the right side is okay. I think the left side is what I'm worried about distally. But we'll take a look here. So nice thing is we didn't lose the lumbar collaterals, right? So Dr. Guja, so what I'm going to do now is I'm going to pull this through the stent again like we talked, right?
Right.
Using this as a sheet. Now I have complete control of my distal aorta, right? Now I'm going to come out, walk it out.
Whatever.
Okay, good.
Hold the sheet.
Yep, I'm holding the sheet here. Okay. So now I'm going to go with an 8-0. Actually, you know what? Let me evaluate the distal part of this lesion first now before I post dilate.
Yeah.
So let's do contralateral. Let's see where my iliac is because my pressure gradient is still not gone on this side.
Yeah, I think there's some
Right.
residual disease distally for sure.
So we got room. So I can put another VBX. Give me another 7-0. What's your short VBX you have? 729. Give me a 729 now.
That's good.
How about using a self-expanding here?
You know what? So let's talk about self-expanding versus covered, right? So the self-expanding stent trial is the ICE trial, right? The ICE trial looked at self-expanding stents versus covered stent versus balloon expandable stent in iliac disease. Now, there was a very, in my opinion, flawed trial that was very surprisingly into JACC. I think possibly the main reason why it got into JACC is because it's a randomized controlled trial, probably the first of its kind to look at this. Actually, I'm okay there. Leave it there. I'm okay. So I think that what we need to say here is that in that trial it showed that self-expanding stents had better patency than balloon expandable stents. So you know, I think in this situation, I mean, it's still heavily calcified. I've already got one covered stent in. I'm just going to put 2 covered stents, be done with it. But I think a self-expanding stent is a very reasonable option here, Vishal. We can definitely do that as well. Ray is going to check our ACT. So you can imagine with all that yapping, it's 9:05. We're an hour into this case and we're almost done. So, you know, I mean, all you have to do is be logical in your approach, make sure everything is done in a methodical, systematic manner, and you're going to be okay. So here I just want to make sure that I don't cover that internal, right? So I'm going to go into this, and then we're going to inject from here, and we're going to see where we are. Ready? So I've got all my pressures are good. Ray's checking my ACT.
No moving. All right.
Ray's checking my ACT, and we're going to just inject now. So what happened to my internal iliac? I'm across it. Go C minus, please.
We can push in a little bit and see.
Minus. So we've got to go in a lot.
Yeah, probably.
Yeah, so Dr. Guja didn't trust me, had pulled it out, and then got us in trouble as always. Ready? Let's try it again. Go ahead. What happened to my internal?
It's there. I think it's just slow flow.
Why is it slow flow?
It's osteum disease.
There's no osteo disease.
It's there.
No, come on. There's no way there's osteo disease. Inject here. Guys, don't compromise. Find your targets before you deploy stents. So there is disease right there, as Dr. Guja did say. But are you injecting strong?
Yeah.
Yeah?
Yeah, there is
I guess you
osteal
pull
disease,
back
PK,
the
I'm telling
sheet.
you. There is osteal disease.
No.
The right side internal iliac has disease, Vishal.
No, I agree. I'm just saying,
You should put me on corner, please.
yeah, just do coronary mode. I guess you might be able to see the osteum better there.
Well, we have a 7 in a 7, so that's probably the reason. I do agree with Karthik. But, you
There.
know, I think Karthik didn't have breakfast. So,
What can I say?
you know,
when PK calls for the case.
let's go up, guys. This is good. I like it.
Pull back a little.
Yeah, I am. Come back slightly. Right.
Pull back a little bit, yeah.
Yeah, go. Just
Go.
pull back slightly. So that's also an important thing because sometimes, you know, one small balloon inflation, a little bit heavier, will give you, balloon inflation injection with a little bit more dye would probably save you dye versus giving, you know, what's nominal? 11. Thank you. Okay, down. So now I'm just concerned about the gradient here. As the gradient disappears, I'm a happy camper. And the gradient
It's better.
is disappearing.
Almost, yeah.
That's okay. We'll balloon it open. It'll disappear. Okay,
Once we get the balloon out, you'll have the, hopefully go up.
Okay, now give me 8-0 balloons, guys.
There you go. Most of it is gone.
Yeah, that's what I'm saying. Once
Both,
you
well,
get
we
the
haven't
balloon.
checked the other one yet. Let me pull the other sheet back, see what our gradient is across the other side.
Good.
So no gradient. So we've accomplished. We're just going to touch this up with 8 O's, and I think we'll do an aortogram, and God willing, we'll be done. And then I think Vishal, it's your turn to
You
buy
wanna
lunch
take a
today, right? Is it Vishal's turn?
It's never Vishal's turn. It's
Oh,
always your turn.
Oh my God!
I don't know why he always keeps telling the junior attendings to get it. You know, it's like
Isn't that what happens when you get older? You can walk around. Isn't that what's happening these days?
you want to take a Dorado?
Yeah, no. I think we just actually may not be. Well, it doesn't matter.
It's covered stand. No?
Yeah, I agree. I agree with you.
Give us an 8 Dorado, please.
But I'm just worried about with the Dorado. Okay. Just if we have these, what do we have open or no? Okay, give me another 8 Dorado. All right, then give me a 20 then. I need a 20 balloon. Well, let's go up together here. You don't have 820s? Another 820? You don't have any 20s? 820s?
No, we have.
Oh, we have one. Okay, let's. I just want to go up with 2 8s. That's all. We got it. What's my ACT?
PK, I think we should talk to Vishal about. Vishal, I think we should talk to PK about cost factor here.
Wow, it's true.
The input versus output ratio.
You know, when we do it, it's like a cost issue, and when he does it, there's no cost factor here.
It's a live case, right? So we're trying to demonstrate the right ways of doing things. I think this is a very important point I think you're making, Karthik. I mean, all jokes aside. I think we always joke around, but I mean, this is a very important point. Is hold on, let me just see where we are.
220 is good.
Okay, go up, guys.
Nice.
So I think this is a very important point that Dr. Guja makes. And you know, I've been speaking to Gore about this, and
A little bit
you
more
know,
in on the down.
You have to go in a
What
little
up?
bit more.
A little bit more in on this.
Yeah, in on the right.
In on the right. A little bit more.
A little bit more.
Touch more. PK, breakfast.
That's good.
so I think again, I could just go back to tell both of you that it's not about how it looks; it's about the gradient, right? So what are you at? 12. Nominal 6.
No, that's
Down?
okay. Yeah, it still didn't expand completely.
Okay, let's go up a little here.
It's my data.
Go up here. 6, guys, not 12. 7, 8. On this side, on the right side.
You don't.
On
you
my
don't do
side.
anything. You don't do anything. I'm doing it.
I think that looks good. It's a little bit of neck there, but
You know what?
Like
And
you said.
we're done with the pressure. Down.
Right.
Yep.
like you said, it's not about
no.
the looks. So we'll just
So
keep it
let's
that
come
way.
down and just balloon the junction.
Wow, look
Walk,
nice.
Karthik, walk yours down. Yep, go up there. Don't you don't
Go.
you're yeah, you go up now, both of you.
Go.
It doesn't matter now. You can go up individually now. Go. It's just nominal. Good. Down. Karthik. You're in the stand. Give me a UF catheter, guys.
Go up again. Yeah, I think you're in the.
No, he's okay. Yeah, he's inflated the whole stent. Down. No. Okay, great. So we have no gradients. So we're gonna go with the UF catheter on both sides. I mean on the on the left side. UF catheter on the left side, guys.
Please don't open another UF catheter, please. We just want one UF catheter.
The problem is the reimbursement for this is very low. Covered stents don't get additional reimbursement. It's expensive, but you know what? It's part of the tools that you're going to need to be successful in this particular case. So, you know, I do believe that's the reason why you have to judiciously use covered stents in iliacs where it counts, and I think even the companies would agree with that. Just because I think, you know, the value of the covered stents really is in patients such as this. The very, very happy news here is we don't have a true proximal seal because we have the lumbars that are still patent. So I want you to understand that even though we don't have a true proximal seal, we don't have any leaks here because of the way we crossed this lesion and the way we did the procedure. So very important from your perspective at home to make sure that you understand that don't get that false sense of security with a covered stent that you're going to have a proximal seal and everything is A-OK. Always do a completion aortogram, right, with this, right? And don't worry about the dye. Make sure you do a nice completion aortogram. And then take a look. So we're going to undo.
This one.
Oh, sorry, that one, okay. And then we're going to prep up. So pressures are all very good, aortic and iliac, so we've done that job. I think he has some brachiocephalic stenosis as well, because as Liz said, his arm pressures are low, and we'll help him with that if he's symptomatic. And we'll take a look now. Okay, give me 10, 15, 1100 now. My friend, take a deep breath in. We'll do it for 2 pictures. Take a deep breath in. Let it all the way out now. Let it out. Totally let it out of your body and no more, okay? Now hold your breath. Don't move. Don't swallow. And do not breathe. Oh, sorry. Mistake. Breathe normally. One more time. Let's practice. Deep breath in. Let it all the way out. And now don't move. Don't swallow. All right, let's do it again. Deep breath in. Let it all the way out. Don't move, don't swallow, and don't breathe.
Beautiful.
Beautiful, though.
Okay. Always wait till the end. Breathe normally. So what am I looking for here? I'm looking for the status of my proximal seal. Okay, I don't see any leakage there, although my lumbars are patent. I've got a good patent. I know I've got no pressure. Now I'm looking at my distal iliacs, I've got good flow in my lumbars on my right side, or the patient's right side. And on the left side, I have an inferior epigastric that I see, and I think I see a lumbar.
Lumbar. Yeah, there is a lumbar, no? Both
There
lumbars
is?
are there.
Okay.
Both lumbars.
Yeah, both lumbars are there.
Okay.
PK is getting older, so.
So now I'm just going to pull this sheet back a little bit, and I'm going to do the same exercise with him and increase my die to 1020, 1100. Okay, my friend, again, we're going to do that exercise. Take a deep breath in, let it all the way out, and now don't move, don't breathe, don't swallow. Inject. So I went a little bit contralateral to my right iliac just to open it up a little more, make sure I don't have any extra. Breathe normally. And now we're just going to look real carefully at the 3 zones that we talked about. Proximal stenosis, a little bit of a recoil that's available in the right iliac, which I'm not concerned with because there's absolutely no gradient between the 2 iliacs. I've got excellent internal iliac flow, good distal seal bilaterally, no dissections that I can see. And I think before we close the case, Dr. Lascano and Dr. Singler will do a quick runoff of the legs, and then we'll be done. So I think in short, it's a very nice case done in probably an hour with a lot of yapping about how to do these type of complex iliacs. So I'd like to thank obviously everybody in our team, especially Dr. Guja and you, Dr. Kapoor, for taking time out of your busy mornings to be with us. And also for everybody in the audience. I really think that this is a case that really has so many teaching points. You talked about from the technique of crossing to anatomic angiographic considerations to equipment considerations to the data. So I think that it's a very, very technical case. It was done, can be done very safely. It can be done, with complications. It depends on how you do it. I hope this has been useful for all of you, and I'll see you guys on December 6th. Thank you very much.
Thank you, PK, for a great presentation. An excellent iliac case, how to cross, CTO, intervention, management options, and of course, follow-up. So thank you, everyone, for joining us. We'll see you again December 6th, an earlier weekend because of the holidays. You can see our previous cases in the archive sections at peripheраlinterventions.org. You can, of course, email us at info@peripheраlinterventions.org for any questions, concerns, or comments. We'd love to hear back from you, everyone. In the meantime, have a happy holidays, happy Thanksgiving, and enjoy the rest of the week. Have a great day. Bye from New York.